Hello, I'm Joshua Zeidner, Associate Professor of Medicine at the University of North Carolina, where I lead the Leukemia Research Group. It's really my pleasure to be here and to discuss some of the really exciting, new impactful data that was presented at the European Hematology Association Congress this past month in June 2025 with future developments of menin inhibitors. So we know that menin inhibitors are quite active in the relapse refractory AML population with either an NPM1 mutation or KMT2A rearrangement, of course, revumenib being the only FDA-approved agent for relapse refractory acute leukemia patients with a KMT2A rearrangement. And at the European Hematology Association Congress, there were several abstracts that were presented now incorporating menin inhibitors into frontline treatment approaches for newly diagnosed AML patients, which I believe is going to make the biggest impact for this new class of agents. One of the presentations was an updated and final analysis from the BEAT AML study, which I have the privilege of leading, and presented this data at EHA. This was a phase 1b study adding revumenib to the azacitidine venetoclax backbone for newly diagnosed older unfit AML patients with either a KMT2A rearrangement or an NPM1 mutation. This was the first clinical trial, again, incorporating a menin inhibitor to the aza-ven backbone for this population. And we reported no maximal tolerated dose with the two dose levels studied of revumenib with azacitidine and venetoclax. Aza-ven was given, at the standard dosing per label. But I think really remarkably, this regimen led to very high clinical activity. In 43 patients, the overall response rate was 88%, composite remission rate over 80%. These responses were quite rapid and deep with no evidence of MRD positivity in those who responded. So this regimen is now moving forward in a randomized phase 3 study that is called EVOLVE-2. And this is sponsored by the HOVON group, which is going to be a pivotal study comparing aza-ven revumenib to aza-ven placebo for newly diagnosed older unfit AML patients with an NPM1 mutation, and KMT2A rearrangements will be included as well. So I'm really looking forward to, obviously, this study being moving forward to see if the addition of menin inhibitors can improve outcomes and survival in this population. A similar study was presented by Andrew Way and colleagues incorporating bleximenib to azacitidine and venetoclax, both in the relapse refractory and newly diagnosed setting. There are several differences in the treatment approach with bleximenib in that study starting on day 4 as opposed to in the BEAT AML study starting concomitantly with azacitidine and venetoclax, but also in their population, very high response rates, I think close to 90% as well. And really, again, corroborating that, bleximenib can also be added safely to the aza-ven backbone with very high response rates. And then finally, we're now seeing emerging data of menin inhibitors with intensive chemotherapy approaches for newly diagnosed frontline AML patients. And Harry Urban colleagues presented the addition of ziftomenib, another investigational menin inhibitor, to 7 and 3 intensive chemotherapy for younger fit AML patients with either an NPM1 mutation or a KMT2A rearrangement, and over 90% of patients responded with either an NPM1 mutation or a KMT2A rearrangement, the maximal dose of ziftomenib being 600 milligrams daily with 7 and 3. So very exciting data. Safety profile seems to be quite reasonable, and this has also led to a randomized phase 3 pivotal study comparing 7 and 3 plus ziftomenib to 7 and 3 plus placebo in this younger fit population with an NPM1 mutation or a KMT2A rearrangement. So there are several other randomized phase 3 studies being designed and planned in both this younger fit and older unfit population with menin inhibitors. And so we await more data, but very exciting for the field moving forward.